Welcome to another episode of the Zach Highley Show. Today, I have the special honor of being with Halle Foss, who is a resident in urology here at Thomas Jefferson University. So Halle grew up in Minneapolis, Minnesota, and went to undergrad at St. Olaf College, a small liberal arts school about an hour south of the Twin Cities. She went to Medical College of Wisconsin in Milwaukee, and ultimately matched out in Philadelphia at Thomas Jefferson University for urology residency. She graduated summa cum laude from St. Olaf and was induced into Phi Beta Kappa. In medical school, she was AOA. She studied abroad twice in undergrad and recently went on a pediatric urology medical mission trip to Amman, Jordan. That's pretty cool. So as always, we're going to start off with some statistics around urology, and then we're going to see what she thinks about them. Okay, so entering residence characteristics. So step one score average of an entering USMD student, so all residencies averaged together, is 232. The step one average for urology was 249. The step two score average overall was 245, and then compared to urology was 249. The 2021 match percentage was 80% in urology compared to 92.8% overall for USMD students. International students matched at a 24% rate compared to the overall international match rate of 59%. Salary-wise, the average salary of a physician is $339,000 overall across all specialties. The average academic medicine associate / full professor median salary in urology is $471,000. For working hours, the average physician works 51 hours a week, while the average urology attending works 58 hours a week. In regards to burnout, the burnout report says burnout percentage was 48% across the board and 49% in urology. And the main reason for urology's burnout, they said, was too many bureaucratic tasks. Any insights, first thoughts on these stats?
I mean, it all sounds pretty much what I thought it would sound like. It is a more competitive field to match into in terms of what your step score needs to be, your grades in school, how many people are matching. I mean, most of the programs are anywhere from 2 to there's a few programs that have 5 residents in a class, but it's overall a smaller class that people are matching into, which I think kind of contributes to the competitiveness of it. But yeah, whether that's right or wrong, I'm not sure in terms of just going based off step scores.
Do you remember, was it pretty competitive when you applied? Was it like a different match rate? Were you told different numbers or?
I was probably told about those numbers. Yeah. My year actually ended up being a pretty good match rate. Really? I think it was in the 80s or 90s my year. That's great. But it always kind of ebbs and flows a little bit. So if there's one year that's a really good match rate, I think more people tend to apply, seeing that match rate, and then the next year it's lower just because more people applied.
Yeah, that makes sense. Have you seen a increase in popularity of urology or a decrease in popularity of urology since you've been a resident, or not really? It's kind of stayed standard.
I think as far as I can tell, it's stayed pretty even keel, but I don't know the exact numbers. Yeah. But in terms, Thomas Jefferson usually has a lot of people apply to urology, so they usually have up to 8 students applying, which is actually a lot for a school.
Yeah. How many spots does Thomas Jefferson have every year?
3 a year.
3. Wow. And I think they get a ton of applicants.
Yeah.
That's crazy. I want to ask about this trip to Amman, Jordan.
Yeah.
I think that's really interesting. Is this the first time you've done this? Why did you do this? What is it?
Yeah, so I have studied abroad before, but I've never done a medical trip abroad.
Yeah, I see.
So one of our pediatric urologists down at DuPont, he is from Jordan originally, so he got connected with this group called the Children of War Foundation, who are based in LA, and they do a lot of mission trips. They kind of started out bringing children to Children's Hospital of LA, providing them care there, and then they would send the kids back to wherever they were from. And then they started doing their own missions where they would send physicians places. So they had this trip planned to Amman, Jordan that was actually supposed to be, I think, 1 or 2 years ago. And then with COVID, it got kind of ixnayed. So he was connected to them through that, and they had room for a couple of residents to go. So me and one of my chiefs went over, and we were based in Amman, and we triaged a lot of kids. Most of the kids we were operating on were Syrian refugee children who were in the camps nearby. And kind of went over and just operated on as many kids as we could, and it was a great experience.
Wow. What is the main thing you're seeing over there?
So a lot of the stuff we were doing isn't necessarily the big life or death surgeries. A lot of it was hypospadias repairs where
what is that?
Where the meatus isn't at the very tip of the penis. It's a little bit down the shaft.
I see.
Which can kind of affect quality of life depending on how severe it is. We did some circumcisions that were for phimosis, not just cosmetic.
And phimosis is not a fun thing, right? That's when kind of the foreskin is just stuck to the top.
Yeah, just you can't retract it
I
back.
see. Okay.
Yeah, so it's just like really tight. It can cause like recurrent infections for kids or be painful. And then what else did we do? We did some orchipexies where if the testicles aren't completely descended down, we can keep them there. Some hernia repairs, things like that.
Was there like a lot of people? Like, were you running out of time to provide all these surgeries? You were.
Yeah, so I think they didn't necessarily anticipate our hit rate on booking surgeries. So we triaged, I think, 60 kids.
Yeah.
And probably could have operated on at least 45 of them. We got through 30 surgeries in like the 5 days we operated.
And is it like a full OR kind of thing, or it's a fully kitted OR?
So this one was. I think a lot of medical mission trips are a little, they don't have quite as many resources there. Amman is actually like a medical like tourist hub of the Middle East. So a lot of people come from countries around the Middle East to get their medical care there.
Wow.
So they have a lot of private hospitals, and there was one that gave us access to their operating rooms, and we used their emergency room to triage kids who came in. So they had their anesthesia staff and their OR like nursing staff, and we even admitted some kids overnight for observation. So that part was really nice that we had like all the tools we needed.
Yeah, I was gonna say post-op. Are there beds around there? I guess there are. That's awesome.
Yeah, honestly, the hospital was really nice. So, like parts of it were nicer than Jefferson. Really? Yeah. So that part was great, and there were some things we brought on our own, like different like tiny sutures and stuff.
So then I guess the reason they need you guys is I guess they don't have the specialists there or the people that can do the procedures. Okay.
Well, they don't have a ton of pediatric urologists in the region, and also we were doing this pro bono.
Pro bono, got it.
So they would need people. They might have like some of the staff that can do some stuff.
Yeah.
But they're working at like private hospitals, and they don't necessarily just like provide a bunch of free surgeries for the Syrian refugees in the region. But a lot of the stuff like the other teams were doing too were really complex, and they probably didn't have people over there who could do it.
Did you like the trip?
It was great.
Yeah.
Yeah.
And you were there for how long? A week? 2 weeks?
About, I think it was 8 or 9 days.
8 or 9 days. Okay. That's awesome. And did you get time to explore the area? You did. Okay.
Yeah, we did a little bit, which was great.
Yeah.
It's a beautiful country.
Yeah.
We did one hike. It was called Wadi Mujib. And it was like this canyon where you're like basically hiking in like this little creek river. So part of it, like the water's just up to your ankles, and other times you're like completely swimming, like through this big cavern, and there's waterfalls.
That's awesome.
And then we went to Petra as well, which is in the southern like deserts of Jordan, which is actually where they filmed one of the Indiana Jones movies. If you want to check it out.
I might go to Petra then.
Yeah, no, highly recommend.
I
if you
won't
get
be
a
able
chance.
to provide some pediatric surgery help, but I will check out. So why did you go into urology?
So it's actually interesting. So there's nobody in medicine in my family.
Yeah, okay.
So I didn't have like going in, I wasn't like, oh, my dad's a surgeon, I want to be a surgeon, which I think is
a lot of people.
It happens for a lot of people, or like you see people in medicine, you kind of get a sense of what you might like. So I was thinking going in that I would maybe want to do medical oncology, but I was like pretty open to everything. I thought I would like surgery, but that I wouldn't want to do it as a career. So when we were picking the order of our third-year rotations, I purposely put surgery first because I thought it was going to be like one of the harder hours and I would just get it out of the way. And everybody said to not do the specialty you want to go into first because you don't look as good when you like don't know what you're doing yet.
I remember that, yeah.
So I did surgery first, and then I was like, oh man, I like really like being in the operating room. I'm like, this is a problem. So I loved surgery. And one of the interns on my colorectal surgery rotation was actually a urology intern because we do 6 months of general surgery our first year. When I was talking to him, he was like, hey, if you like surgery, at least go look into urology and like see what it's like before you make your final decision. And the way I had organized my schedule, I didn't really have room to put an elective like early enough in my year for it to make sense with the urology match. But we had at Medical College of Wisconsin, it was nice. We had a lot of Thursday afternoons off during our clinicals for just like your own personal time. There was random Thursdays we would have to do some stuff. But I used a lot of those Thursday afternoons to go shadow. So I would go like into the clinic or into the OR with different urologists and just really liked the variety in it. Truthfully, at the beginning when he said look into urology, I was like, do women even do urology? Like, I don't know if that's a thing. It's going to be weird. Like, people don't want to see a female. But there were a few like female attendings there, and I got the sense that it was like not a big deal at all, which it totally is not. There's more and more women going into it.
I think that's the same initial thought some people think with like OBGYN, right?
Yeah.
They think like, oh, guys, there's not going to be that many guys in there. But I think the numbers they're coming closer to the middle in both respects.
Yeah, exactly. The overall, like if you look into the workforce right now with attendings, I think it's only 9% female. It's around that number. But it's increasing. And I would say there's some residencies that are 50-50.
Wow.
We have 4 women out of 15, so decent numbers.
More than 9%?
Yeah, exactly. Yeah.
So do you think if you didn't have that initial experience with that urology intern, you would have ever discovered urology?
It would have had to be like happenstance.
Yeah.
Because truly, I didn't even really know that urology was like a surgical field. Yeah. I thought it was going to be really narrow where they don't have a lot of variety in their practice just because I thought it was so specialized. But then when I started shadowing, I realized like how many different things they do. There's a lot of clinic procedures. There's a lot of just like medical care. They follow a lot of patients who they never operate on, and you're following them their whole life for their urologic care. So there's that aspect to it. There's a lot of like endourology procedures where it's same day surgeries. There's big robotic procedures. There's big open procedures if you really want to get into all that stuff. So you can really tailor your practice to what you want it to be.
Was there like a moment when you were doing this shadowing or where you're like, I know it, this is urology for sure, gung-ho all the way, I'm going to do research, 4th year I'm going to load up with my summa urology, or was it kind of like a slow burn, or how did you know? Because it's tough to go into surgery and say, oh, I'll try urology, but then be like, oh, I'm definitely doing urology, right?
No, it is hard, and I think I don't know that there's necessarily like this is the only thing for me. I don't know that is ever like completely true for someone. I think I could have been happy in multiple things, but I knew I liked surgery. And then when I got to urology, I really loved the people. A lot of the urologists I've worked with are really down to earth, just like the subject matter you're dealing with every day. You're talking to people about really private aspects of their life a lot of the time. And so a lot of the people are just really down to earth and easy to talk to. And I liked the variety of their procedures. We have a lot of fun toys in urology, a lot of lasers, new stuff coming out all the time. So I liked it as much or more as other surgical fields, and liked that I would be kind of subspecialized from the get-go, as opposed to general surgery where you do general surgery and you almost have to do a fellowship to subspecialize after that. So kind of a combination of all of that. I was like, yeah, let's go for it.
Yeah. But did you know right away? Because I think the first thing we're told as medical students in our 2nd or 3rd year is decide like medical or surgery, right? Medicine or surgery kind of thing. Did you know for sure, like right away? You didn't know. Okay.
No, I think that's kind of a crazy thing that people say.
Yeah.
For some people, I think
too.
it's totally true.
Yeah.
But there's also like medical fields where you're doing a ton of procedures. So I don't think you necessarily have to know like surgery or medicine. And I think I went into it like looking for that. Like, oh, I thought I was going to be like a medicine person per se. Like I was thinking medical oncology or maybe GI, and thinking like, oh, everybody says like you either know right away that you want to do surgery or medicine. And I was like, wait, but I like both of them.
Yeah.
So I don't think you necessarily have to go one way or another. And I think it's okay to like both. And I don't know. And a lot of people say too, like if you think you would be happy in anything other than surgery, do that.
Yeah, they say that a lot.
And I don't think that's true either, because I think I could be happy in some of the medical fields. Like I loved hem-onc was also really interesting to me. And like, again, something like GI or interventional cardiology, you can do procedures and other things. But I'm also really happy in surgery.
How much on the scale of like medicine to being in the OR do you think urology is? Do you I think of, for example, a cardiothoracic surgeon, something like that, and I think it's skewed like way you're in the OR all the time. But then you of course have clinic days and stuff like that. Is it the same as most other surgical specialties where you have clinic or is it more you know what I mean?
Yeah, I think it's a little skewed of how people think of it. I think people assume if you're in surgery, you're like always operating.
Yeah, I thought that.
And it is a lot of clinic. And in residency, like our 4th and 5th year are purely operative here at Jefferson. So like I will be in the OR every day that I'm at work for these 2 years. But in practice, that's not the reality. So I would say most of our attendings probably are in the clinic 3 days and in the OR 2 approximately. Sometimes that switches where they might have a week they're in the OR 3 days and clinic 2 days. But usually one of the clinic days is procedures as well, where you're doing cystoscopies to evaluate like blood in the urine or pull a stent that was placed. And you can do like vasectomies in clinic, prostate biopsies. So usually I would say it's like 2 days of clinic, 1 clinic day of procedures, and 2 days of OR is probably the average.
Got it. And then the first year of residency, at least here, you do 6 months of general like surgery, and then you go after 6 months you go into urology.
It's kind of however the schedule works out.
Okay.
Like I actually started on urology because they'll usually have 1 intern on urology and the other 2 here are on their gen surg rotations.
I see. Okay. And then the second year, what's the second year like?
The second year here, you rotate at Jefferson for 4 months, at Methodist for 4 months, which is like a smaller community hospital in South Philly. And we also rotate down at Nemours in Wilmington, Delaware, as our pediatric hospital.
And you're doing like procedures there or procedures clinic or?
I would say it's mostly OR as a 2, and you're kind of just starting to learn a lot of the endoscopic skills, how to cysto, how to treat stones, bladder tumors, that kind of stuff. You do have some clinic when you're at Jefferson with Dr. Huboski, who's one of our stone experts. He's one of our really advanced endourologists who's phenomenal to work with. And then at DuPont, or I guess it's called Nemours now, we do clinic and OR there.
Got it. So first year is like you're kind of doing some general surgery, a little bit of urology. Second and third year, you're doing mostly OR with the occasional clinic?
Third year is our most clinic.
Yep. Okay.
So we're at Jefferson the entire year, and we have like 3 different services that kind of mesh together when you're in the hospital, but for the purposes of like kind of splitting up attendings and who their point person is, we split them up. So our A service is 3 attendings who do mainly oncology. B service is a lot of endourology and some robotic stuff like minimally invasive. And C service is our like reconstructive, kind of men's health kind of stuff, female pelvic reconstructive surgery. So you do, the third years are kind of with the attendings of their respective services, and they are either in clinic or the OR. So some services you're in the clinic 3 days a week and other ones on like 2.
Got it. How's the workload like as a urology resident?
It's a lot. I mean, it's a surgical residency for sure. I think people think about urology as you're going to have like an easier life than a general surgeon and like it'll be a lot more chill, and that might be true in practice. But in residency, it's still a surgical residency. So you have the same hours, you have a big workload. At Jefferson, we're lucky to get a lot of autonomy, but that also translates into maybe a little more work outside of the hospital as like a tit for tat kind of thing.
What are the hours like?
It depends on the year.
Okay.
So let's see. I would say third year is one of our busiest years as a service resident. So usually we are going through the list in the morning with everyone around 6:30 most days. Some days it's like 6 or 5:45 if we have conference and stuff. But you have to round on whoever you're expected to round on before that. Yeah. So however much time it takes you, depending on how big the list is. I would say I usually got in around 5:30 and probably left the hospital 6:30 to 7-ish most days, unless the OR went long for some reason. But just because you leave the hospital doesn't mean you're done working.
You writing notes and stuff like that when you get home, or?
Yeah, not so much notes necessarily. Third year, we pre-op a lot of patients. So you're responsible for making sure that patients have, if they had a urine culture collected, you make sure it's treated before they go to the operating room, make sure they have cardiac clearance. And you're kind of just like double checking everything. So there's multiple sets of eyes, making sure that patient's safe for surgery and ready to go, and they don't need any further workup before they're going under anesthesia.
So first case is like 7 a.m. kind of thing, or?
First case starts at 7:30.
Got it.
And then on Thursdays we start at 8:30 because we have conference in the morning. And
then weekends. Do you have a lot of golden weekends? Is it like 1 gold, 1 black, and then 2? I forget the other color.
Yeah, ours is a little more simple than that. Okay. I think we have night flow, which is really nice.
I see. Okay.
So Sunday night through Friday night, there's a junior in-house overnight.
Got it.
And they are just working night shift. They go home during the day, sleep, come back for a night. And there's a chief on backup call. So the juniors in-house is the main like contact person. They'll see the consults. They'll do anything that comes in. And if they need help with something where they like can't scope a catheter in on the floor, or if somebody needs to go to the operating room or someone's getting like admitted or discharged, they'll call the chief. But otherwise, they take care of everything in-house. And the chief only has to come in if it's something bigger that they have to help with. On the weekends, there's a junior in-house as well. So we do like kind of power weekends where you start Saturday morning and you are on until Sunday at 6 p.m. So it's home call. You can go home. It tends to be pretty busy on the weekends. Yeah. But again, there's a chief on backup call. So your junior's in-house, either a 2 or a 3. And the chief comes in to like round in the morning, kind of see all the patients, make sure everything's okay. And then if anything has to go to the OR, they come in and different things.
What are the big, I just out of curiosity, what is the most common like emergencies you see in urology? I
would say the most common one is like a septic stone.
Okay.
Wow. Or any sort of like urinary tract infection and the kidneys aren't draining well. So if you, because they can get sick really fast. So if you have a urinary tract infection and a stone that's obstructing, that urine can't drain down to the bladder, and you get something called pilovenous backflow, where all that urine with the bacteria kind of gets pushed back into the venous system, and you can become bacteremic and sick like very quickly. So those are the people we take to the OR like immediately. Even if they might be stable, a lot of times we act pretty quickly to stent them because they can go downhill quick.
Get really sick really
especially if they don't have reserve.
Got it. Even if I guess even no matter, because it's like one ureter as opposed to the other ureter, it doesn't matter that the other kid, it's just in the blood, you're getting bacteria, so it's bad news bears. Yeah.
So we always say if someone's obstructed, the reason to stent someone is any obstruction with a UTI, unilateral obstruction in a solitary kidney, where that's like your only kidney that's making urine, or bilateral obstruction.
Wow.
Sometimes their creatinine is like through the roof. They have bilateral obstruction. They might not be infected, so they're not like having fevers. But if their kidney creatinine is going up, then you.
So let's fast forward a year and a bit, and say you're starting as an attending, and say I let you practice as an attending for 3 years.
Okay.
After that 3 years, I give you $100 million. And I say, hey, you're welcome. And I say, hey, now you have the option. I'm going to say, I've given you $100 million. You can either continue working full-time as an attending. You can work part-time as an attending. You can switch careers, or you can go live on a beach. What do you think you would do? It's hard because it's 5 years in the future-ish.
Yeah, I feel him. I'd be too young to just like quit everything altogether. I think I'd go crazy.
Yeah.
But I might work part-time, at least for a while.
There we go, finally. That's great.
Does everybody say they would just keep working?
Well, most people are like, I work full-time. It's my passion forever, blah, blah, blah. Some people are like, for example, the Dr. Lawless, he was saying, I maybe spend some more time with my kids, but he never said that. So
he never truly said part-time.
I think I would, too. I think I would work part-time 100%. 100%, so thank you.
Yeah, I do think it would be tricky at the beginning because you would have to have like a smaller patient census, and then it's difficult for patients to follow up with you if you're only part-time because you're like only there certain days.
You can't be like a moonlighting consultant urologist, right? Or anything like that?
I think you technically can, but it's not common.
It's not common. Because that way you don't really need patient continuity.
Right.
You just like go to the hospital occasionally when they need you and stuff like that.
Be a urologic hospitalist.
Yeah. That could be cool. That could be, we could create that. We could create that specialty. That's awesome. So what is the best thing about being a urologist?
The best thing about being a urologist, I think the people are one of the best things. Okay. I love everybody that I work with, and it seems like kind of across the board, like on the interview trail, different programs I either rotated at or interviewed at. Just the people are great. So they're fun to work with. I think there's a lot of ingenuity in urology. We're advancing the field really quickly. Even from like when I started as an intern, there's a lot of like new tools and things that we use. Like we're using the single port robot for some stuff now instead of a multi-port robot.
What does that mean? You only need to put one kind of...
So our classic multi-port robotic surgeries, you usually have 5 or 6 ports in. The single port, it's a little bigger incision, but we usually make one of the incisions bigger at the end to take out whatever we were taking out anyway, either a kidney, prostate, bladder, whatever. So it's a single port, and all of the arms go through that port.
Oh, that's cool.
Yeah, so it's interesting. I don't know how much utility it's going to have.
Yeah, I'm wondering if you have worse. I mean, I know very little about this, but I'm just thinking generally for if you have 5 ports, right? For example, you can get things at a different angle, but if you're just coming right here and it's something's behind you know what I mean? I guess.
Yeah, it's hard because all of your arms are in view.
Yeah.
When we use the multi-port, like one arm can be out of view, kind of retracting something for us. So it's taking some getting used to. I haven't personally operated on it yet, but I've seen it.
And it still goes through the same, like you're in the same kind of hood and stuff like that, the same user interface.
Yes, oh man, what are they called?
The Da Vinci thing?
Yeah, like the console that you're sitting at is all the same, but the robot itself is different. So that's something newer that we're like starting to look at. We use a lot of like disposable ureteroscopes now that have like digital cameras that have a beautiful picture compared to our reusable scopes. We just started trying out this like vacuum device where when we go up into the kidney, you laser stones and then you have to pluck out all the pieces. And sometimes the pieces are just like dust and it's hard to like actually grasp them. And for most people, that'll all wash out normally. For some like spinal cord injury patients or patients who are bedbound, it doesn't wash out as easily.
I see.
And for years, we've all said like we just need like a vacuum to just like suck out the kidney, and they finally have something. That'd be a
good invent. I feel like that's a great missed. I don't know. I feel like it's cool to know about these little things because if I was a urologist, I'd be like, I want to jump on the next thing.
Yeah.
The problem is if you invent it at Jefferson, under Jefferson, they get everything, right? So you have to.
I'm not sure exactly how it works.
This is me thinking selfishly and wanting to make tons and tons of money. Because I'm trying to think. Because I know there was an anesthesiologist at Jefferson who invented a better spirometer during surgery or something like that, and he did very, very well. He did very, very well. This is completely off the point. Okay, the counter question to what is the best thing about being a urologist is what is the worst thing about being a urologist?
Oh man, I think one of them is that most people have no idea what urologists do.
Yeah.
I think even other physicians don't know. I don't think we learn a lot about it in medical school. So I think it's fair that people don't know, but it can be annoying to get like consults for things that are not necessarily a urologic problem, or just like family and other people like really don't know what you do for a living.
Yeah.
They kind of think you're just the penis doctor.
Do you want to tell us? Do you want to give us what is a urologist? Tell us.
Well, oh man, that's a hard question.
I know.
I think people just don't know the scope of it. A lot of people don't know that it's a surgical field, so they don't know that we operate. We're dealing a lot with oncologic problems, kidney cancer, prostate, bladder, testicular cancer. We do pelvic organ prolapse for females. We do pediatric urology, so a lot of congenital problems. People with spinal cord injuries, MS, Parkinson's have a lot of issues with function of their bladder from all of the neurologic connections being damaged or not working for some reason. We do men's health, erectile dysfunction. There's a whole scope of things that we do.
I didn't know you guys do with erectile dysfunction. That's interesting. I guess especially if they did procedures or something like that, you'd need to step in. That's
For what?
If it's, for example, is it just like if someone comes up and they say I have erectile dysfunction, they'd come talk to you, or is it a second point after? You know what I mean? Like, would the primary care physician be like, you have to go see a urologist? Because I get confused because there's like, we're definitely going down a little rabbit hole here, but there's like sexual health doctors, right, and stuff like that, and I don't know, it's just.
I would say urology kind of takes the forefront in a lot of that, at least for men's health.
Yeah.
So, like, primary care physicians will prescribe, like, Viagra and different medical therapies, but if that's not working...
Then you take the next step.
Then they usually come see us, or some people will just come see us at the beginning. A lot of times, too, our procedures can cause erectile dysfunction. So if we take out someone's prostate...
That's what I was thinking. That makes more sense to me,
Yeah, so there's medical therapy. You can do injection therapy into the corpora to cause erections. That works a lot for spinal cord injury patients. And then there's also implants like penile prosthesis that we do surgery for.
So as an incoming internal medicine resident, can you tell me what's a good consult and what's a bad consult?
Oh man. Well, I think it's never necessarily bad to call and ask if you don't know.
Got it. Okay.
There are a lot of things that we can just kind of curbside tell people about.
Yeah.
Which is totally fine. If you don't know something, I don't think it's bad to call someone else to like ask a question. There's a lot of Foley problems that we get called about that are not necessarily a hard Foley.
Like you can't put the Foley in? Kind of
like nursing tried to straight cath, it didn't work, so we have to put it in now. I think that every physician can put in a catheter. That being said, I realize that like someone who's been like a hospitalist for 10 years has probably not put in a catheter in like 5 years. So like, should we expect them to do it? Probably not. But I think learning how to use a coude catheter is something.
What is that? I don't even know what that is.
It's like it looks like a catheter, except
Yeah.
there's like a tiny like bend at the tip.
Okay.
So it helps get past a big prostate.
I see.
And truthfully, they are like so much easier to place than a lot of catheters.
Coude
If it's for
catheter.
someone who's like an older guy
Yeah,
with a big prostate, and that's the reason you're having difficulty. And nursing can place them. There's a lot of nurses that do. But then there's others that like hear a word that they don't know, and they're like, I don't know how to do that. I'm not doing it.
What's the difference? The only difference in training, I guess you just, when you first go in, it's at more of an angle?
Yeah.
That's it?
You just have to make sure the angle's up.
Yeah.
And if it's not, it doesn't hurt anything. It just doesn't go.
It just doesn't work. It doesn't do its purpose. What is the most common myth, you think, so from the lay public about what a urologist does or is?
I think most people think it's not surgical. I think a lot of people know that it's like prostate related.
Yeah.
So it'll be like, oh, when men have to get their prostate checked, they go to a urologist. And I think it kind of ends at that. Like there's a lot of women who have stress incontinence that maybe don't realize that they can go see a urologist, and there are therapies we can do for that, or like overactive bladder we see.
Yeah.
So I think people maybe don't realize the extent of what we can help with.
Yeah, no, that definitely makes sense. So the next question I have is, and again, these are tough questions. You might not have the answer. It's putting you on the spot here. Do you have any memorable experiences with like patients or even with other residents or just procedures in general? Anything that pops out to you that says, you know, this urology thing's pretty cool, or this patient experience was pretty cool? Like I wouldn't go in, I know you came in with a very open mind, but maybe this was, you know, not necessarily going the down ways, but saying like, oh, this is actually really, really cool.
I think not necessarily like one specific patient, but just in general, I think a lot of the stuff we do is quality of life based, which is really nice. Our patients tend to be very appreciative. So like if you come in with a ton of pain from a kidney stone, they can be like very painful. And we admit you, put in a stent, bypass, so your urine's draining okay, your pain is gone immediately. So people are so appreciative with that. And I think a lot of people take for granted just like being able to pee normally. And so if we can help someone who is having issues start peeing normally or divert their urine a different way, it just really improves their quality of life, which is a really great aspect of it. And a lot of the cancers we deal with too, some of them are bad, but a lot of them have really great survival rates. Like prostate cancer, even if you're diagnosed with metastatic prostate cancer, you can live for 10 years with the therapies we have. So I think it's a little different than something like pancreatic cancer, where you know off the bat that their lifespan is probably not going to be great regardless of what you do. I think we can really help people if we detect things early and intervene right away with like bladder cancer, prostate, kidney cancer. A lot of times we just do a partial nephrectomy and we keep doing scans every year to follow them, but that's curative for a lot of people.
Are there any screening procedures that should be done on kind of most people by urology? You know what I mean? I'm just trying to think.
So most of the screening usually starts with their PCP. So PSA tests for men. Usually I think it's when they're 50 or 55 is the recommendation right now, a little earlier if you have a family history. And if the PSA is elevated, they would come see us to see if they need any further imaging or a biopsy. If you have microscopic hematuria on like a urinalysis, then you would come, if you have it like multiple times and you have like a smoking history or anything, usually they would come see a urologist. We would take a look in their bladder to see if there's anything going on and get some imaging. But yeah, usually a lot of the screening stuff is done by a primary care physician and we get referred or in the ED or something.
So if I'm a third-year medical student and I hear about urology, but I like you, I didn't have any experience in it and stuff like that, but I think I might be interested in it. How could I go about learning more about urology and maybe getting some practice possibly in it?
Yeah, so I think reaching out to, honestly, any of the residents or a lot of the faculty to say like, hey, can I just come shadow one day, see someone in clinic, see someone in the OR, kind of see the differences. If you're really gung-ho about it, there's some great lecture series online. So during COVID, University of California, San Francisco did a whole like COVID lecture series that were all online and they're archived. And it's basically like a bunch of like big topics in urology from a lot of the leaders in the field that would just do like a Zoom lecture. And that's all out there for free for anybody who wants to watch to see like if there's one topic that piques your interest, then you can watch the lecture on it from someone who's like one of the major leading people in the field. Yeah.
So now the other side. So you're at the beginning. Now the other side. So like beginning of fourth year, maybe when you're a week away from submitting your applications and you're not sure. You say, I like urology, but maybe I also like general surgery, or I like maybe even medicine or something like that. Is there anything you would tell to these students how to kind of finalize your decision and figure out for sure, even though nothing in this life is for sure, right? But for now, to make the decision of urology or not?
I mean, I think you have to be okay with working in a surgical field where anything in medicine, your hours are going to be a little up in the air. Like if you're inpatient for medicine, you might not get out at the same time every day too. But I think it's a little more up in the air for surgery. Like you might be there till midnight operating if the case is taking longer than expected. We have add-on cases all the time that we try to call for at different times, and sometimes we don't have OR staff till 9 p.m. So that's when we call for the case if it's something that needs to go overnight. The hours are long during residency, but you can really tailor your practice after. So I think if you want to be in like a procedural field, then urology is great.
That's good. Make sure you want to do procedures, right?
Yeah, exactly.
That makes a lot of sense.
Yeah, like my fourth and fifth year, I'm only in the OR.
Yeah. And
so,
you're looking forward to that.
Yes.
Good. Yeah, good.
So you have to be okay with that too. There's also other people who are in urology who already know they don't want to do the big, huge procedures where people are getting admitted for 5 days after and the complication rate is higher because it's a major surgery. They know they want to do more like general urology, be in the clinic a lot, do some more like general urologic procedures, and that's going to be their practice, and they'll do amazing. But you have to do the bigger stuff in residency.
Yeah. No, that makes sense. Now, urology is a competitive field. How did you attack maybe specifically your application, or what are your suggestions to people that are interested in urology to making themselves more competitive? And this could span anywhere. This could span, when you first go into medical school, say for some reason I want to do urology. How can students make themselves more competitive? Because it is a harder match for sure than some of the other specialties when they're applying for residency.
Yeah, I think it's changing a little bit because I think step one was a big kind of weed out score for a lot of programs. And now that step one has changed to pass fail, unfortunately, I feel like it's going to make step two a bigger deal.
Yeah.
And your grades on your clinical rotations.
Yeah.
I think have always been a big thing.
Yeah.
So I think keep an open mind going into third year and try hard on all your rotations. They don't want to see that you just did well on your surgical rotations and that you blew off psych and medicine and all these other things. Like they want to see that someone's going to work hard in anything they go into. Having good relationships with people always helps for any field. Once I decided that I liked urology, I jumped on a bunch of research projects and kind of reached out to different residents, and you work hard in that and try to get stuff at least going before your applications due. I don't think it has to be in urology, but it helps. But if you have research in anything and you can prove that you can take a project from like conception of the idea to publication, I think that's all they're really looking for is someone who's going to work hard and follow through on something. So again, it helps if it's in urology because it's something to talk about during an interview, but I don't think it needs to be.
Got it.
And then anything else that you're passionate about is always helpful.
Yeah.
Like if you do like study abroad trips, or you like were in engineering and a bunch of cool stuff with that, especially in urology, there's a huge aspect of medical device stuff. So, and honestly, anything else you're passionate about, if you can like prove that you've spent a lot of time on something and have something to show for it and can talk about it.
Like volunteering and stuff like that? Okay.
Yeah, for sure.
Because I remember when I was just applying to med school, it was like, you got to get your volunteering, resurgery, and all this kind of stuff.
Yeah,
but
tick all the boxes.
It doesn't need to be urology. That's an interesting statement. It's just showing that you're kind of passionate about research and you can take a project from beginning to end.
Yeah, because I think a lot of people know that a lot of people don't encounter urology till later in medical school unless you have like a parent or someone you know who's a urologist, or you happen upon it earlier. I think it's not uncommon for people to discover it in their third year. So to expect everybody to be like, oh, I've been working on my urology application for the past 10 years is insane.
It's tough. No, it's great. And maybe that would be a down thing as opposed to
right.
Who knows? So you're fourth year. I keep saying you're third year. I don't
That's
know why.
okay.
Because I don't just comes to my head. But you're a fourth year now, like me. That's how I can remember it. Like,
There you go.
Yeah. Have you ever been burnt out or felt burnt out or felt like things were so hard that you want to quit?
I haven't been to the point where I like want to quit because
Yeah.
I can always kind of see the light at the end of the tunnel.
Got it.
Like I
Okay.
know this is a temporary
Yeah.
thing, but I've definitely like been very fatigued and tired at different points of residency. Intern year, there's a lot of long hours where you're on the floor a lot. You're not in the OR. You see all the other people doing all the cool stuff, and you're kind of running around doing the scut work, which is just the nature of anything, really. In every residency, you're going to do that as an intern. But it's a steep learning curve. So you're putting in a lot of long hours. You're getting a lot of things wrong. You're there for a long time. So it takes a lot. I think for any field, you have to be someone who takes constructive criticism well, because it'll only help you. Mm-hmm. Even if someone comes off as you think someone's being mean, just take what they're saying and change what they want you to change.
Yeah.
And just move forward from that, because that's truthfully all anybody's asking you to do.
Yeah.
Some people just aren't as it's kind of us saying things sometimes.
I've seen some things. I feel like it's better than back in the day, quote
right?
unquote. But yeah, I've seen these things. Did you use any strategies? You said you would look towards, you knew this, you saw the light at the end of the tunnel. Did you do things like, I don't know, did you go to yoga classes or take weekends away, or was there something for you that you found that worked when you were feeling kind of down or kind of like there was a lot going on?
Yeah, I think you have to try to keep some semblance of a life outside of work.
Yeah.
There are like weeks where it's just like not possible.
Yeah.
But then when you do have time, like take time to hang out with friends. Like I was friends with a lot of the general surgery residents and the other urology residents who are going through the same thing as you are. Mm-hmm. So you can kind of pick their brain about what they're doing and talk about what you're all going through together, which helps. So take time to like see your friends outside of medicine too. Like I have some friends up in Brooklyn who are not in medicine. So it's always a nice like weekend getaway if I could go hang out with them and kind of just like escape the medical world for a while. If you can find time to exercise, I always feel a lot better when I can at least do something. It doesn't need to be insane. Like just go for like a 20-minute run or something and kind of clear your head. It helps.
That's great. And then we're going to step out more generally now, not necessarily urology, but thinking about lifestyle, thinking about having a successful long-term career. And this doesn't necessarily need to be in wellness. It could be in finance, in the actual field you're going into, or anything. Do you have any kind of advice or things you've been thinking about? Because you're kind of at the beginning, right? Because you'll be an attending in a year.
Yeah.
Going forward.
In terms of what?
It could be anything. It could be like finance. It could be lifestyle. It could be, what did someone, for example, the Dr. Lalski was mentioning, I wish maybe necessarily I didn't wait so long to start a family and stuff like that, because he feels like he's getting a little bit older now.
Gotcha.
And he feels like maybe I want to be around for my kids as long as possible, and I'm a little bit older, they're a little bit younger and so on and stuff like that. But it could be any, what was another Dr. Okasani, who's a cardiothoracic surgeon, said in his training what he would do every single day is he'd have a little notebook. And he'd have a little notebook that when he would go through a procedure or something like that, he'd write down the steps of the procedure, and then he'd also write down. He seems like insanely focused. He's wonderful.
He gave us a lecture one morning, and
he seems awesome. But he says, he'd also write down the attending preferences, and then he'd also, when he went home at night, he'd read for at least an hour or two every single night on whatever was going. And I was like, you are really setting the bar up.
Yeah,
really,
that's a lot.
Really high. That's a lot.
I will say, especially in a surgical field and probably anything, the attending you're working with is going to give you a longer leash if you know what they like.
I see.
So we have multiple surgeons who do robotic prostatectomies, and there are certain steps that each of them do a little differently. And if you are doing the steps that they like to do as you're going, they let you keep going because you know
what they do.
You know what their steps are and what they're doing next, so they trust you to keep going the way that they would want it to happen. So I do think that's an important part of kind of like knowing who you're working with. And after you graduate, you can do it however you want. Like you can set up your own way of doing things. But it's good to know like who you're working with, how they like things done, and kind of cater to that, because they're going to give you a lot more autonomy if you show that you've been paying attention when you're working with them.
So pay attention to what the attending specific preferences and steps are. That makes sense.
Yeah. And not to say that you can never like question something that's happening, but if they have like a very specific way of doing a procedure if you try to change it up, they're probably just going to take it away from you.
Give me the reins.
Yeah, exactly. So that's definitely important. In terms of after residency, a lot of people do fellowships versus just going into practice, or there's academics in private practice. So it's all stuff that I'm still trying to figure out right now.
Yeah. Do you have any leanings on any way? Yeah.
My plan is to apply for a robotics fellowship.
Okay.
So there's like the Urology Society where there's kind of a mix of fellowships within that. Some of them are very robotics focused. Some of them are endo focused, like stone treatment, upper tract disease. And some are like a mix of both. So I'll probably apply to that with the goal of something that's a little more robotics focused. And then I don't know if I'll end up doing academics or private.
Now we're going to step back even further. If you could speak to 18-year-old Halle going into the field of medicine, undergrad, for going into her first higher education, would you give her any advice? Would you tell her anything before she ventures down this long, honestly long road?
I think just go into everything with an open mind. I think every year you feel like you have like no time and it's the hardest year yet and you're getting crushed, and then the next year you're like, oh, I actually had a lot of time last year. So just like take advantage of the time that you have, and use your time wisely, and don't forget that there's more to life than just medicine.
There's other things to do other than just be medicine.
Easier said than done.
Have you seen, so two-part question. Are there attendings that you have seen make mistakes? And they're not necessarily procedural mistakes. I mean, like career mistakes, like, for example, lifestyle decisions, or it could be mistakes in the OR, but say maybe it was not a technical mistake. I mean, like an attitude thing or something mistake that you want to make sure you lean away from.
I think there's definitely people who are a little more impatient.
I see.
In the operating room, and I don't think that it necessarily helps situations. So I definitely want to strive to be someone who doesn't have like an immediate reaction.
Snap.
Like I think you have time to like step back and think about things. Even when things are tense in the operating room, I think you can handle it well. Even if something's like serious, I think there's a way you can talk to people that's more helpful. So definitely, that's going to be part of my goal as an attending to not like snap at people.
Person.
Yeah.
That's great.
So we'll see.
We'll see. Yeah, who knows? Maybe as soon as you get the cloak of an attending, things happen and you're just, throwing things. No, I wouldn't think that.
Yeah, because I think the better relationship you have with people of any level, like the nurses, the custodians in the hospital, anybody can help you. If you are on good terms with people, like it can only be better.
Yeah. No, that's a really good point. Make sure to... Because they're also, they're humans too, right? So just
yeah,
be nice
they're humans, and they're doing a lot of work in their own right too. It's just different work.
And then selfishly, it'll pay off in the end. I've seen it too. If you're nice to these people, they'll help you out, right?
Exactly.
And it'll make your life easier. And, in the end, that could mean also better outcomes for patients, right? So it's a whole thing. Okay, so you've seen attendings that maybe make mistakes. On the other side, are there attendings you admire, and are there certain aspects or qualities of them that you aspire to be like?
Yeah, definitely. Try to think of specifics. I mean, I think you can tell when an attending like truly cares about their patients and spends the time to talk with them through everything and doesn't just blow things off. I think there's also people who, if they're like more specialized, they think that some things are beneath them. Like if someone walks into their clinic that's not like their exact specialty, it feels like they don't care as much maybe about that patient when that patient's just coming in to like get help about their problem.
Get better. Yeah.
So if it's something you don't know, I think it's totally fine to just tell the patient like, hey, this isn't what I deal with every day. I'm not exactly sure. Here's who you should go see. But I think just like the people who like care for their patients, you can tell.
Yeah. They're
a little more invested in like talking to the families after and like making sure everything's set up pre-op and talking to the patients.
That's great. And now this is kind of a weird question, but do you have any book recommendations around medicine? If you had a book that someone should read before going into medicine? A lot of people mention Atul Gawande's book, or When Breath Becomes Air is a very common one people mention. I love that book. I thought it was just really interesting to read. What else do people mention? The House of God is mentioned a lot, kind of maybe on the other side of saying, it's not so glamorous what we're doing. There are things that aren't the glamour to it. Is there anything, and it doesn't have to be medical, right? It could be something Someone mentioned atomic habits the other day. They thought developing their habits and getting in the way that they should, especially as their lives become busier and busier and busier and busier, establishing their habits now and their kind of how they live their life now was really helpful when their life got busier, so they knew kind of what to do. Is there any books? It could be anything. It could be a fun book too.
I don't know that I've read any that I necessarily would be like, you have to read this before you start residency. I know The Emperor of All Maladies is like a big medical book that a lot of...
The Emperor of All Maladies.
Yeah,
okay.
I don't know that it necessarily like helps you in residency, but it's kind of the history of cancer treatment.
Wow.
And like how kind of aggressive and almost barbaric things were at the very beginning, where it was just like, they talk about a lot about breast cancer. So like radical mastectomies, where it was like a very like high morbidity surgeries they were doing for patients. And then they moved to like lumpectomies and radiation and different things. So it's an interesting journey on the like history of cancer treatments and where we started and where we've come to. I don't know that necessarily
The Emperor of All Maladies. No, that's great. That's right. I haven't heard that one before, so that's interesting. Awesome. So I think we're coming near the end here. Do you have any closing words for people, students specifically, maybe a third year or an early fourth year, who's interested in urology? Anything you think they should think about, or any just closing remarks in general for people that are thinking about urology as a specialty?
Yeah, I mean, in terms of like in medical school, I think keep an open mind to everything you're going through. If you have an off afternoon, it's really easy to just like do nothing with it. But go shadow in different fields. There's a lot, you don't have time to see every field. So like I never saw ENT or IR or anything. Maybe I would have loved those. Anything you think you might be interested in, just go shadow, keep an open mind. Work hard in everything, even if you know it's a field you're absolutely not going to go into. You're probably only on that rotation for like, 4 weeks?
Yeah.
Like, just put in effort to learn everything you can from it, because it might be the last time you ever like see that specialty.
Yeah.
And then, work hard, get in contact with people, do some research in something.
Yeah. That's fantastic. Because you may have never got into urology, right? I'm stuck with this initial story. Because I sometimes think a lot of this, life's random and stuff like that, but it seems kind of happenstance. Dr. Okasanya, I was talking to him, he said he had an amazing experience with a cardiothoracic surgeon who helped him and guided him and said, you know what, you could be a great surgeon in this. And it was like, wait a second, this is what I can do. You know what I mean? This is what I can do. So I almost think like, what if maybe I just never had an experience with an ENT doctor or an IR doctor? I think that's a really good tip to kind of dip your toes in everything, and find your people too. I think is a good thing that people say a lot, and I think that makes sense to me as well, because these are the people you're going to be around them probably a lot of the time more than your family or friends and stuff like that.
You're with your co-residents a lot in residency, so find the people you get along with. Actually, for my story of how I got into it, I actually applied for weight rotations in urology before I had a specific rotation.
Wow.
So sometimes you just have to make it work with how your schedule is lined up. I think a lot of people have a lot of stress with the order of their rotations. You can make it work.
Oh yeah. They kept on telling us that in third year. I mean, I remember. They'd be like, don't worry, it's going to work out. People are hardcore surgeons and they got it as their fourth rotation or their first rotation. They were freaking, but it does. It all works out.
You can, if you think you want to do something and your rotation's not until June of your third year, reach out to people earlier. Go shadow. You can get to know people without a formal rotation.
Well, perfect, Halle. Thank you so much for coming. This was really, really helpful.
Yeah, thanks for having me. It was fun.
Thank you. And we're out.
And we're done.
And we're closed.
Dun, dun, dun.